Hi, I'm Dr.Gerald Deas. Welcome to Health Center from Downstate Medical Center. Have you ever seen a black child who can't give you a smile because the pains in their joints are so great? The answer is easily found when you find his blood count down because the cells that have sickled easily break. Now the child didn't ask for this when life gave him a kiss, that he would have to suffer such pain and woe. So come on and join the band, give this little black child a hand and let his blood flow so he can grow and grow. Well, that's a song on sickle cell anemia. It was recorded by Brooke Benton over 30 years ago. It was actually the first song about a disease and describing what the disease really is, which is sickle cell anemia. Well, when you think about 30 years ago, sickle cell anemia today is it's the same disease, but many more treatments have taken place through the years to alleviate the pain, to give the patient a longevity of life in a sense, be able to go to school and do all the things, and it never affected their intelligence or anything like that. It was always just a painful blood disorder because the cells that usually are around, for some reason, because of genetic reasons, turned into sickle, a shape of a sickle. You know, the thing that the farmers used to use to cut wheat, that was a sickle. And when they got like that, they would jam up the blood vessels. And by jamming up the blood vessels, the blood couldn't flow freely through the brain, the eye. When you look at how small our blood vessels are, it takes very little for clumping to take place. And when clumping takes place, the tissue is not oxygenated adequately, and so it's painful, very severe pain. In fact, I had sickle cell patients to tell me that when they have a crisis like that, it is the worst pain you could experience in a lifetime because it is severe pain, oftentimes needing very heavy narcotics, morphine and things like that, just to reduce the pain so the patient could get some rest from the pain. Well, a lot of things have taken place over the last 30 years, and thank goodness for our research folks here, even at Downstate Medical Center and all over the world, because sickle cell anemia is not only here, it comes right over the continent of Africa and India. It's in a lot of other places too, and it's mixed up with other genetic diseases and so forth. But it is a condition that seemingly they say it might have developed over a period of centuries and centuries to protect the person from malaria, because seemingly the parasite that causes malaria could not affect the cells, and so when the cells sickle as such, it actually prevented the pain and things like this, or the malaria more or less would not be able to take hold of the person. But we have today a very dear friend of mine, Dr. Scott Miller, who's been here for all these years, 30 years, and has done a lot of the basic research in this disease, and we're going to bring up some of the new concepts of what's going on right now and give you some of the old concepts of what sickle cell disease really is, because many of the people are not being genetically counseled today because they're just not taking the test and it's not a requirement, so they're still having sickle cell babies still being born. So I want to welcome you, Scott.
Hi, nice to be here.
Nice having you, Scott. And you know, maybe just a little background on your history in pediatrics. Has hematology always been your thoughts of coming into pediatrics, or how did you get into hematology? That's the study of blood.
I can't say I've always wanted to be a hematologist or even a doctor. I took a lot of science and math in high school and college, and things got a little abstract, I guess, in the math particularly, and a number of my friends were going to medical school, and it seemed like a good job to have in terms of using some science and thinking and seeing sort of a direct benefit in terms of helping people and treating diseases. I actually did a fellowship at S.U.N.Y in New York Hospital, and was exposed to a lot of oncology, and I do some oncology as well as
What is oncology?
Treatment of children with cancer.
All right.
So people who specialize in the field of pediatrics specialize generally both in hematology, which is blood disease, and oncology, which is cancer. At S.U.N.Y we saw a lot of cancer. Obviously here we see less of that, although we do treat children with cancer here as well. When I arrived here in 1981, my chief at the time, Dr. Audrey Brown, who did a lot of the early observations about children with sickle cell disease. Had a very good support from the NIH to do something called the Cooperative Study of Sickle Cell Disease.
I see.
Which ultimately went on for 20 years, documenting in about 4,000 sickle cell people the natural history of the disease. And I think a number of important papers came out of that. And certainly it got my attention, and I have tried to sort of fill in her footsteps over the years and continue what it was already a tradition of taking care of people with sickle cell disease back then when I arrived 30 years ago.
Well, you know, it's really interesting. Before you did arrive, I was here at Downstate also as a student and an intern and resident. And of course, there was a Dr. Watson and a Dr. Robinson who was hematology department at that time. I became interested in sickle cell disease through my being taught by them. And of course, like you say, so much developed even after you got here that they didn't even know at that particular time.
Well, you mentioned Dr. Watson. She actually, I think in 1956, wrote a paper that first described the fact that newborns with sickle cell disease weren't affected by the disease. And she speculated, and I think proved, that the reason was that they still had fetal hemoglobin circulating. All of us, when we're in the womb, we have a different kind of hemoglobin that helps deliver oxygen to the fetus. It has different properties in terms of carrying oxygen, which is what hemoglobin does. It carries oxygen to the various parts of the body, feeds the tissues. And she noticed that babies with sickle cell disease for the first few months really didn't have any complications of the disease, and it turns out that that's because they still have a lot of fetal hemoglobin. Red cells normally last about 4 months. They last much shorter with sickle cell disease, but the fetal cells lasted well in these infants with sickle cell disease. And so over the first few months, they were protected from sickling by fetal hemoglobin. People have noticed subsequently that in some types of sickle cell disease, those who have higher levels of fetal hemoglobin as older children and adults tended to do better as well. And that's what sparked the interest in whether or not we could give medication that would increase the amount of fetal hemoglobin. And one of the reasons I'm here today is to talk some more about hydroxyurea, which is a medicine. It's a pill that you take by mouth. One of the local pharmacies actually makes a liquid that we can give to smaller children who can't handle pills. And it was first looked at because it does raise fetal hemoglobin. A number of chemotherapy medicines do. I don't know if we can get into the whys. I'm not even sure it's clear exactly why that happens. But hydroxyurea is the safest of the chemotherapies. It's one that can be given once a day by mouth, whereas others have to be given by injection. And a number of studies were done, I guess, over the 70s and 80s, and there was a big study in adults in the early 90s that showed that indeed hydroxyurea does raise the fetal hemoglobin. It does impact on the severity of sickle cell disease quite substantially. And in the mid-90s, actually, hydroxyurea was approved for use by people with sickle cell disease, and in fact recommended by authorities that people take it who are having problems with the disease.
Did it have hydroxyurea? Did it have any specific side effects that maybe that folks had to be careful using it in all patients? Or?
I think the main side effect really is it can lower the blood count, the white cell count. Now, we showed in the cooperative study, and other people have suggested that people with sickle cell anemia have high white counts, and that those people tend to have more difficult courses, have more problems and complications. So there's a suggestion, at least, that lowering the white count, although it's a side effect of the disease, and it means we have, of the treatment, and it means we have to see people every month and check their blood and make sure the white count doesn't go too low. We actually like to see some drop in the white count and use that as a target in adjusting the dose of hydroxyurea to try to be sure we're getting the most that we can out of the medication once we've decided to use it.
Now, you know, as a resident and treating sickle cell disease without having that great drug that's on the market today. Pain was the most important thing when we saw a sickle cell patient in the emergency room, which required heavy sedation, painkillers, and things like this. And I was always impressed that when a patient did not have pain, they were not asking for pain medication, becoming addicted to it in a sense, And so I was it was really interesting to know that people who have to take pain medication does not necessarily have to become addicted to it if they're using it for pain as such, And so maybe you could just discuss this pain business, because the pain is the thing that most parents are concerned with when the child is at home or, and so forth.
Well, certainly if you have pain from sickle cell disease, it is severe. And we routinely would give opioid therapy, narcotic therapy to those people. Pain episodes in children last an average of about 4 or 5 days. Adults, it's a little bit longer. And if it's just 4 or 5 days, then usually we can give morphine as our frontline drug still for treating pain of sickle cell disease. We can give that for 4 or 5 days, and the child can go home often to continue an oral kind of opioid for a few more days if they're still having some pain. We use the more common and non-addictive things like ibuprofen, which is Motrin or Advil or Tylenol, acetaminophen as well. But really the pain, unfortunately, opioids really are the best painkillers we have, and I feel strongly that the children who have sickle cell pain need that in order to be remotely comfortable.
Right.
As I say, it lasts a few days. Usually it's not a problem. If it lasts longer, then I don't think addiction is the word, but people can become tolerant of morphine, and they may need more of it. After a week or two in the hospital of getting opioids, they may need to go home on some opioids to kind of slowly taper or to stop, because you can have withdrawal symptoms after a week or two of opioid therapy. I think healthcare providers worry too much about their patients getting addicted to opioids, and we tend to try to protect them from themselves, if you will. But really, I think that most of us are overly protective, and we probably should be concentrating on more whether the child is saying that the pain medicine is adequate and is helping it as best it can, because as you said, people describe sickle cell pain as being some of the worst imaginable. Sure. And we should picture ourselves in the position of having somebody tell us, well, I'm going to give you this much medicine, and I could give you more, but I don't want you to get addicted, so I'm going to let you suffer a little bit.
Yeah. As far as African Americans, or maybe low percentages are African Americans, and which carry the disease here in this country as such. Can you tell me, is there any better genetic counseling today, or is there genetic counseling for people who are getting married and they're going to have children and never have a sickle cell test? Maybe you could give some comments on that whole question there.
Well, they should have a sickle cell test, and not just a sickle prep, which is a screening test we used to use. The reason being that while the sickle prep will pick up carriers of sickle cell disease, it won't pick up carriers of beta thalassemia or hemoglobin C or hemoglobin D, or some of the other hemoglobins that, when combined with sickle cell, can cause a kind of sickle cell disease.
Right, yes.
So you really want to be sure that you've done the proper test, which is called hemoglobin electrophoresis, or HPLC is an abbreviation for that, and be sure that you've been screened not only for sickle cell, but for the other conditions that might occur with sickle to cause problems.
Right, but in our community, I'm sure people are not aware that they should be tested. Years ago they used to, for syphilis, they would put silver nitrate in eyes and all this kind of stuff. Test you for, you couldn't get your marriage license, in other words.
For syphilis,
for syphilis,
I don't know if that's true, by the way, anymore.
And it's not, but the whole thing is, but in sickle cell, being a genetic disease, if people have a trait, maybe you could talk about the trait, and then if the traits get together,
Yeah.
how disease
Well,
can
I
form.
think it should be done, as I say. It is recommended by the American College of Obstetrics and Gynecology, and certainly if you have a family history, or if your ancestors are from Africa or the Caribbean, there's certainly a chance you could have sickle cell trait. Something like 1 in 12 African or Caribbean Americans have sickle cell trait, so it's not
Trait.
rare.
It's
Trait.
not the disease, but
Right.
they don't experience any of the symptoms,
Yeah.
but they have the trait.
Something like 1 in 400, 3 to 4 to 500 actually have the disease in Brooklyn.
Right.
We keep track of that, and at Kings County or Downstate every year, the risk of having a child with sickle cell disease is actually 1 in about 200s if you include the SCs and S.Thals and some of the other variants of sickle cell disease. Basically, if you know you're a carrier of sickle cell disease, you should find out if the potential father of your children or your husband is also a carrier of either sickle cell or C or thalassemia. Because if they are, then you need to know that you might have a child with a serious blood disease, and you need to talk to the genetic counselor and your obstetrician about what you can do about that.
Well, that's what I'm saying, Scott. Information is around, there's plenty of information, health information, but how it's dispersed to the general population, people are still ignorant about it. And of course, people don't like to predict, I'm going to have a child with this disease, but it seems to be, if all you need is one child with the disease, those testing the mother and the father certainly would be important to see whether they have the trait.
Yeah, and if they both do, then there's a 1 in 4 chance that their child will have sickle cell disease.
Right.
You can, by having special tests early in pregnancy, by 8 to 10 weeks or so, it's called chorionic villus sampling, or CVS, determine whether the fetus is affected by sickle cell anemia.
Right.
And it would be an option to terminate that pregnancy if that was something that you are comfortable with.
Dr. Miller, hydroxyurea is a drug now that's being used now to kind of prevent this sickling. And maybe we could just get into a little bit of discussion on that and how well it's being used, not only when people have sickle cell anemia, but even if a baby might be in utero or early in time might be able to be treated with this medication.
Yeah, we've been using hydroxyurea in children, and it's not yet approved by the FDA for use in children. It is for use in adults with moderate to severe sickle cell disease. We use a lot of medicines in pediatrics, though, that are not formally approved because it takes a lot of money for a pharmaceutical company to do the studies that result in improvement.
Surely.
With hydroxyurea, about 10 years ago, the federal government enrolled 10 centers. We were one of 10, and then additional 4 or 5 centers were enrolled 5 years later. The goal being to put 200 infants with sickle cell disease, and to enroll in the study, the infant had to be from 9 to 18 months old. They had to have sickle cell anemia or sickle beta 0 thalassemia. But otherwise, we didn't select them for having had problems. We just we wondered whether hydroxyurea would be good for everybody, starting at a young age, because damage from sickle cell disease starts at a young age.
Right.
Primarily, we were looking at spleen function and kidney function, which are 2 organs that are damaged early. We weren't able to prove as conclusively as we would like an impact of hydroxyurea on those organs, I think, because they're very bad in terms of circulation, and sickle cells tend to injure them easily. Also, we could have probably picked our measures of spleen and kidney function better. But there is a suggestion that early hydroxyurea started. I said the average age of the infants that started this study was 13 months. And by one measure of spleen function, 40% already had diminished function by the time they were enrolled on the study. So even though 13 months is young, it's not young enough to save some spleens. At any rate, the infants were recruited. Half of them got hydroxyurea, half of them got sugar water. Nobody knew who was getting what. And they were treated for 2 years looking for complications of sickle cell disease. as well as specifically looking at the spleen, the kidneys, and some other tests. And the results of that study were just published in The Lancet. It is available online if you search for it. It was in the May 14th issue. And the results to me were very impressive. It showed that the number of complications, even in infants with sickle cell disease, was substantially reduced by taking hydroxyurea. The chance of having a pain episode in the hands and feet, which is one of the early signs of sickle cell disease, was reduced by about 70% in the infants that were taking hydroxyurea. Pain episodes, pneumonia, hospitalizations were all reduced very substantially in the group who took sickle cell disease. Hemoglobins didn't drop as much. White counts did drop, and we think that may be beneficial in the long run. And there were really no side effects except for the drop in white count, which we follow carefully and we expect and we look for, in fact, in terms of seeing if we have an adequate dose of hydroxyurea. So I've over the years become a very much a supporter and prescriber of hydroxyurea for children. There was some question in writing the paper about that study is what does it mean? Certainly I think it means if you're having trouble with sickle cell anemia, your doctor should talk to you about hydroxyurea and you should strongly consider taking it. Some people even think that any child with hydroxyurea should start taking it very early just because the damage does begin so early. There's some suggestion that hydroxyurea might help even that early damage. And I think I'm in that camp. I talk with parents of infants with sickle cell disease. I tell them about hydroxyurea. If they want it, then I will give it.
That's right.
Even if the child hasn't had any problems yet. Most children will have problems with sickle cell disease. There are some concerns about potential long-term side effects. We've looked at for some blood tests that predict a chance of malignancy as a result of hydroxyurea. None of those tests were revealing. I mentioned the adult study that was done in the 90s. They've followed those people they just published a paper with 17 years of follow-up, and they looked for any evidence of extra cancers or leukemias or anything else in that group of people, and they haven't found any. In fact, I think importantly, they found people that took hydroxyurea for most of those 17 years were living longer than people who never or just took a couple years of hydroxyurea. So in adults, it's good. It reduces pain, it reduces acute chest, it reduces hospitalization, transfusion, and it extends life. And in infants, it does all those first three things. And we're going to be following the infants who were on that study for another perhaps up to 8 or 9 years to see if we see any bad things and to see if the good things are sustained or not, as most of them continue hydroxyurea on a prescription basis now that the study has ended.
Well, I was very impressed from the standpoint as a doctor treating sickle cell anemia here at Downstate, and the number of blood transfusions that sickle cell patients have to take, and how many of them ever developed AIDS. Well, even before the AIDS virus was found, in a sense, how many of them really came down with AIDS because of an infection from all the transfusions that they got. And I didn't see that many sickle cell patients with AIDS. Now, is that my impression, or is that something that seemingly is real?
Well, there were some, just as AIDS was being discovered, there are people with sickle cell disease who need to have transfusions every 3 or 4 weeks because they've had strokes or other serious complications. And thalassemia is another group who don't make enough blood. They need frequent transfusions. I think the incidence was about 10% before AIDS was discovered and screened for. Now the risk of getting AIDS from a blood transfusion is somewhere between 1 per million and 1 per 4 million people have estimated per unit of blood. So it's not completely eliminated, but obviously the odds of getting it are very small. And usually when we give blood to somebody with sickle cell disease, there's a good reason for it, and I think the risks of not giving it would be greater than that 1 in a million risk of getting AIDS. You mentioned transfusion, and again, although the risk of AIDS from blood transfusion is much lower, there are people who object to transfusions for other reasons, even religious reasons, and I think people should know that people who take hydroxyurea are clearly at lower risk of needing a transfusion, and if we have Jehovah's Witnesses out there who have children with sickle cell disease, that would be something they might want to consider as treatment with hydroxyurea.
Time has gone by so fast, but we're going to have a continuation of this discussion because it's such an important thing in our community, and Downstate is certainly on top of these kind of things and giving cures for this condition, and genetics we have to talk about and so forth, so we'll have to take this up at another time. But I want to thank you for your work that you've been doing here in sickle cell anemia, because you've been one of the giants here at Downstate to carry on this research and a community that needs it because of the numbers of African Americans that live in this community from the Caribbean as well as Southern African Americans. And so I'm just glad that we are taking advantage of the having your research done here. And so I want to thank you for being with us.
Thank you. It's a pleasure, always.
Yes, right.